Thank you so much, Mandeep. We hope we can hear you, or you can hear us well. It's a very noisy place, so thank you for that. So my name is Lawrence. I'm really excited to moderate this very important panel for us here at M42 and generally Abu Dhabi and the region. A panel that looks at the interface between genomics and prevention, particularly from an angle of premarital screening, and really underlines this word, screening, right? Where global health is sort of failing, and we believe here we can really make a difference. So I just want to make two little introductory points. One, that premarital screening is not particularly new. Sexually transmitted disease screening before marriage started at the beginning of the 20th century. And by the mid-70s, there started to be, in the US, premarital screening for things like thalassemia. And since then, in the sort of 50 years since, there's been a gradual increase in the number of diseases that can be screened and diagnosed through such programs. Abu Dhabi comes to change the scene here through the power that the Emirate has developed in genomics, and particularly the Emirati Genome Program. The Emirati Genome Program is a massive program. One of our panelists today will comment on this extensively, but in essence, we were talking about almost 1 million whole genome sequences that one can go back to visit again and again and again for a number of different applications and purposes. So I think I'll leave it there in terms of introductions, and I'd like to maybe start our discussion from Mrs. Wadha, and maybe your comments, Wadha, on the broad how premarital screening powered by whole genome sequencing genomics reflects the vision of the Genome Oasis.
So, the Genome Oasis vision is primarily to enable a healthier population through the power of genomics, making precision medicine accessible, as well as reducing the disease burden by innovative research and global collaborative. While the mission of the Genome Oasis, as well as the Emirati Genome Program, is to identify the genomic factors impacting health and diseases among the population, increasing the genomic literacy, as well as integrating the precision medicine within the healthcare system and the healthcare strategy, allowing for better healthcare outcome.
Thank you so much. Thank you. My next question goes to Albarah. Albarah is the M42's Senior Vice President for Operations, the guy that I have the pleasure of working very closely with, and has spent more decades than I'd like to share in and around labs. So the question, Albarah, for you would be, what does this mean for M42 in terms of the contribution, the technological and operational contribution that M42 has had for a program that is quite significant in scale?
Thank you, Lawrence. Maybe just to step back a bit, I don't like to answer the question direct to the point because I know that's what you want. But I think it's more important to really understand the impact of this program, the vision that the UAE leadership has had on bringing a new generation free of inherited rare genetic disorders. Just take that into concept for a second here. We could potentially, through a program like the premarital screening, powered by the Emirati Genome Program, have a new generation that is free and negligible of inherited rare diseases. That is profound, in my opinion. Lawrence alluded to premarital being a standard type of screening program globally, but again, with limited resources, limited applications, it can only address a small part of the problem we have. With the vision that we have through the Department of Health and Abu Dhabi Public Health Center and the other regulators within the UAE and the leadership, we're able to address over 840 diseases, 560 different genes. Why? Because we have a universal genomic passport for every Emirati citizen that can be sequenced once, used for life. And I think that is the profound vision here that is coming to realization through the premarital screening as one important, but only one application of the Emirati Genome Program. I forget what your question is, but I'll try to go back to it. But I think based on the infrastructure, we're very fortunate at M42 that we have been appointed the trusted partner of the Department of Health and Abu Dhabi Public Health to bring these into fruition as in operations. So we have one of the largest genome infrastructures in the UAE, one of the largest in the world actually here, born out of the UAE. It has capabilities of sequencing over 300,000 to 500,000 whole genomes on an annual basis. But more importantly, we have the brilliant minds that have come on board to support these programs under the vision led by the Department of Health of how we can take this massive amount of information and data that's been generated. For every single individual, we're generating over 3.2 billion data points. So how do we get the most out of this information is really where the scientists, the bioinformaticians, and more importantly, the infrastructure, the sovereignty of this data set, securing the information is critical to such application. So that's a very long-winded response, but
it's a great overview of vision and strategy. And I'll come back to my more operational question in a bit, and let's make sure that this time you might even answer it. I'll pass to Tiago. Tiago is our vice president for bioinformatics, and of course, we have a very significant analytical task here. So there are over 750,000 whole genome sequences, about 110, 120 petabytes of data, and the exercise is to go through these bioinformatically and identify risk. So I think I'd like to ask you, Tiago, from a bioinformatic perspective, what does this mean for you? And how would you describe this program from your perspective?
Yeah, so as you're saying, it's a very large task because this is the largest data set of genomics in the world, which is incredible, right? And as Albarah said very, very well, and I think that it's incredible to think that this could mean change one country in one go, because rare diseases could be very, very diminished in this country in one generation. That's the power of that the leadership of this country has decided to embark with this data set. So from the point of view of how you do it, and infrastructure is great because when it reaches me, it has so many people have worked on this that is extraordinary. When it reaches to me, there is a lot of computational, there is a lot of linking up with databases that tell us what are the genes, what are the variants. You need to go through very large sums of genetic information to get it. You need to match the possibility of the couple to get it. You need to know that it's recessive. And of course, this is a great task, and the challenge is also immense, and the joy is immense, and the situation where you see the impact, right? So it is extraordinary. So you need a lot of cloud computing, you need a lot of people to do this, you need a lot of matches, you need databases from the outside, so it's a complex task, but again, the impact is so large that it's a joy to be working with this.
And Tiago, maybe before I go to our next panelist, bioinformatically, how do you express this impact? I mean, is there a discovery element here? Is there an insight generation side to this? Because otherwise, of course, you see it as a screening program that impacts genetic burden, genetic disease, not genetic burden of genetic disease. But what about the new insights that this program could unearth?
You're pushing me into a very technical answer, which I'm going to avoid. No, of course, the fact that you have variants which are well known in the population, and we can match that. It's a very large task, but you can match that, and that's not really new insights. The problem with that is that it is the variants from the Western population that has been discovered, and this program has the opportunity to get you new, novel variants, which should be incredible, and even novel genes that will not only good for the population, but could get point of entry into disease. So you could be finding new genes into rare diseases that can give you more biological knowledge, which then gives you new drugs, can give you new insights into disease, and this is one of the most exciting bits. So you have novel variants, and you have novel genes, and all of that is powered by this data set, and of course, I have to say also the infrastructure that M42 has built around this.
Excellent answer. I'll just take a minute to add a couple of points for our audience. this point that my colleague Dr. Tiago mentioned is paramount, and it's really runs a torpedo through the Western dominance and inequity of genomics globally, and how underrepresented this region is, but also massive regions like India or Africa or Central Asia. So the statements from the notes from Tiago really are notes of, I would say, genomic equity in a way also. Yeah. Dr. Mariam, to you, Madam Athane, thank you very much for joining us today.
Thank you.
What key measures, from your perspective, has Abu Dhabi Public Health Center taken to enable the program?
Yeah, so first of all, I would like to thank you to giving us this chance to reflecting our role as Abu Dhabi Public Health Center. It's a unique center which is crossing the region, which looking for the community health from early detection of these diseases. And one of these diseases is genetic diseases. As you said, Dr. Lawrence, when we have started with the Premarital in 2009 and 8, it was very basic, limited screening elements, which only screening the infectious diseases and the very limited genetic, which is thalassemia and sickle cell. Unfortunately, UAE is having a high prevalence in hereditary and genetic condition. We have successfully implemented this program, and we have beginning that in Emirates of Abu Dhabi, and we have screening for this genetic screening for early detection to prevent and for early intervention. In addition to that, we have a lot of key measures that enabling this program. One of them, which we work with hand-to-hand with our genome office in Department of Health, to standardize these standards across the best practice. And also we have working with our workforce to upscaling our physician. When we piloted this program, it was one of our challenges that we don't have that much genetic counseling across Abu Dhabi or across UAE. We have successfully upscaling this physician to be able to counsel this patient. In order to success of this program, we have to be able to address the correct message for our community and to know exactly what the risk factor of this condition. The other elements that we are proud that we implemented within the Abu Dhabi Public Health Center, which is a follow-up unit, which we call the Premarital unit. This is a unique unit. It will follow all positive cases. Once they get the results, it will support them in both parties, either a behavior or scientific elements. So we will be ensured that this patient or these individuals with a positive outcome receiving the correct message, and he have chosen the right decision that to continue with this marriage or no. If the patient, for example, or the positive cases individual agree to continue with that marriage, we will be ensured that we refer this to IVF centers to complete and to have a healthy population for our next generation.
That was such an excellent answer. Thank you so much for that. I think it just contrasted so well the technological and analytical aspect of the program with the very complicated human, ethical, and operational side of the program. Because really, I mean, for the parents amongst us, and the ones, and we can all imagine, this is a very serious thing to happen to you, right? I mean, it's not an easy thing to go through. So it's fantastic to hear the structures that the government has built around this. And just to remind ourselves why these programs are so difficult, because the technological part is really the core enabler, but then you have all this complexity of dealing with the most precious thing, the human. Thank you again. My next question goes back to the operations of this from a technological and a sort of laboratory perspective. And I go back to our Senior Vice President, Albarah, for your reflections, Albarah. One of the complexities here is that this is not a single test that is prescribed to the individual. This is a capability that's built for the emirate to deliver at scale. So I'd like you to comment on this word scale, Albarah. What does it mean for you?
Thank you, Lawrence. I just want to tell you a bit of a sort of story that enabled. So when the premarital screening started as a concept, one of the major challenges that the Department of Health had, to us at least as the operator, is that we want to reduce the turnaround time as much as humanly possible. So just put this in perspective. You have an entire whole genome. If you were to go to any hospital provider today and request a clinical grade whole genome sequence, probably 8 to 12 weeks on average. Maybe you pay a lot more to get it in 4 to 6 weeks, but it is a matter of months to get this type of result. And we're dealing with the same element of complexity, the amount of data that we're sitting at. And I recall that we were set a target maximum of 14 days. And those are not business days, those are calendar days as well, because the Department of Health doesn't like to make it easy for us. So we knew that the only way to achieve this was through automation and through infrastructure capabilities. We're sitting on 700 to 800 whole genomes. How do we seamlessly, from when the order comes in for the premarital, first of all, find these two individuals that have consented to perform this test, find the whole genome, and combine this whole genome within the database that's been curated by the team, and seamlessly move all of this information and data through the pipelines, the clinical pipelines, look specifically at these 560 genes, looking for common carrier screen, and then be able to report it in automated fashion. So when the team was set that task, after a full cycle of about 6 months worth of work of developing these automated pipelines and so forth, if we have quality data sitting in our database, whole genome sequences, today, if they are negative, like there's no positive finding, we've tested this, that it can within 28 minutes produce a whole genome negative common carrier screen report for premarital screening. Obviously, the positives require a significant amount of due diligence, review from the clinical geneticist, but when you screen all the negatives, which the vast majority are, and you can focus on primarily on the positives, you reduce the risk of error because you have something called negative fatigue reporting within a clinical domain. When you're constantly reporting negative after negative and you get to a positive, it can slip through. So you primarily focus only on positives. It allowed us to meet and exceed the 14-day turnaround time. So we're very fortunate today. Our average turnaround time is between 6 to 8 days for the entire premarital, and you're talking about thousands of individuals going through this program across the entire UAE. So that's how we're able to scale this program.
Thank you so much, Albarah. So we've had a bioinformatician comment, a stakeholder from Abu Dhabi Public Health Center, a lab operations expert, and I'll just go back to the Department of Health now, Wadha. If you can just briefly describe the premarital screening program from the DOH perspective.
I think Dr. Mariam Ahmed Al Wahedi explained it very well, as well as Albarah. However, I'm going to clarify that this is an expansion of an existing mandatory testing. However, the previous test was looking into 2 genetic disorders. Today, we are looking into 570 genes responsible for causing 845 autosomal recessive condition. And the rationale behind the expansion is that UAE ranks the 6th globally in terms of genetic and partially genetic birth defect. And this is due to the high consanguineous marriages in the UAE. So this was an evidence-based approach, similar to was conducted in 2008. So they conducted a premarital campaign related to thalassemia, which led to a 50% reduction in the cases. So we are aiming to provide the couples with the needed information to better plan for their future and to have a healthier generation, inshallah.
Thank you so much for that answer. Yeah, the opportunity for impact is massive. I do have a question asking Tiago to try and quantify that, but I think I might bypass that and go back to Abu Dhabi Public Health Center for your views, Dr. Mariam, on how other initiatives fit into this strategy next to premarital screening. How does ADPHC wish to complement this with more initiatives?
Yeah. Before answering this question, I will step back to Albarah, what he's saying when it's focusing about the turnout of the result of the premarital. Yes, we have pushed to be within 14 days, but when we compare it with the other previous screening, previously it was only 3 to 5 days. So really, we have a challenge with our community to convince them to accept that it's 14 days accepted for them, and to do the screening in advance at least 1 month to 2 months before their marriage. As you know, our community, they have get used to have a result within a couple of days. But the genetic, we are successful with M42, we reduced that turnout period. Backing to your question regarding what the other initiative can be linked with premarital, I believe we, all of us here, we have one shared vision. It is to reduce the prevalence of the hereditary condition within the Emirates. And we have successfully implemented this program. And successfully, we piloted in Abu Dhabi since 2023. Then we implemented in October 2024. In order to let us, this is the beginning of the genetic screening program within Emirates Abu Dhabi, and will give us a full journey that we have to think about what other screening program that can be tackling this genetic program. And successfully with DH Genome team, we will be inshallah launching and preparing the newborn genetic component, which inshallah will be implemented in very selected maternity hospital. It will capture more than 700 genes. It will capture, as you know, our regular screening for newborn screening, it's only capturing very limited genetic screening, which is HELPEX screening test for metabolic disorder and the congenital heart disease. But with the upcoming component, with the genetic screening elements, we'll be able to screen the deficiency of C5 and C6, and we'll be able also to do another screening for another genetic related to diabetic and the other metabolic disorder. I believe all of us looking for a healthy population and for a healthy generation.
Thank you. I think we'll close with that fantastic answer. Thank you again very much, Dr. Mariam. I think the panel did a fantastic job at exemplifying the power of the Emirati Genome Program and how mass-scale whole genome sequencing can enable prevention and screening in very meaningful ways, not just in nice words that we want to tweet, but actual, real ways. It makes me feel very proud of Abu Dhabi, M42, and the Emirates of really leading, I believe, globally in this. So join me in thanking this fantastic panel today, please. Thank you.